Good morning, Dr. Rajesh.
Good morning, sir. Good morning.
Good morning. Thank you. Thank you very much. Bharat, you are ready?
Yes, sir. Good morning, sir. I'm ready, sir.
Yeah, please start.
Okay, sir. Good morning, faculty, my dear colleagues. Today's seminar on surgery for pancreatic necrosis. The initial surgery for pancreatic necrosis was first described in the late 1800s, and since then it has undergone many changes, and especially in the last decade or two, a lot of changes due to a lot of research, understanding the pathophysiology of pancreatitis have led to better outcomes in pancreatic necrosis. Just a quick understanding of the types of pancreatitis. The most common is the interstitial, which is around 80 to 85%, and the necrotizing, which occurs in around 15 to 20%. Now, in these, there is a complication of an acute fluid collection in which it can be sterile or infected, or when there's a pseudocyst which forms around it after 4 weeks. And the same with an acute necrotizing pancreatitis. Within 4 weeks, it is called an acute necrotic collection, which can be again sterile or infected, or a walled off pancreatic necrosis. And it has been shown that usually infection occurs after 2 weeks of the inciting index pain. Now, this is a CT scan here showing a collection which is heterogeneous, fully encapsulated in the pancreatic and peripancreatic area. Data suggests that 80% of the deaths associated with acute pancreatitis are due to infected pancreatic necrosis. And when pancreatic necrosis is present, there is a 15% mortality. As per the CTSI grading, it is shown that above 30%, the mortality increases further. And if it is more than 50%, mortality reaches up to 60 to 70% also. And infected pancreatic necrosis, mortality increases up to 40%. The traditional method, which was the open surgical necrosectomy, had high complication rates, range up to 40 to even 90%, and mortality up to 30%. So the disadvantages with the open necrosectomy were increased perioperative stress, leading to MODS, external fistulas, and also if there were chances of diabetes and exocrine insufficiency, and if the patient eventually survived, there were high chances of incisional hernias in long-term follow-ups. The first study to counter the open necrosectomy approach first was the step-up approach versus the open necrosectomy, done by the Dutch Pancreatitis Study Group. This was published in 2010. It was called the PANTER trial in the New England Journal of Medicine. In this, the step-up approach was compared to the open necrosectomy, in which the step-up approach consisted of percutaneous drainage, followed by minimal invasive retroperitoneal necrosectomy if needed. And the primary endpoint was a composite of major complications, including MODS, other complications such as perforation of visceral organs, intracutaneous fistula, bleeding, or death.
Rajesh, please feel free to interrupt and ask or comment in between.
Can we stop him in between, or should we?
Yes, please. Yeah.
Okay. Thank you so much.
So may I continue?
Yeah,
yes, please.
The PANTER trial showed that new onset multiple organ failure occurred less in patients who underwent the step-up approach. This was significant, and 12% versus 40% in the open necrosectomy group, although the rate of death did not differ significantly. And the patients assigned to the step-up approach had a lower rate of incisional hernia and new onset diabetes. And another important finding in this study was that 35% of patients in the step-up group did not need necrosectomy at all, and were drained sufficiently with just PCDs. The same study on the long-term follow-up also showed less exocrine insufficiency and a trend towards less endocrine insufficiency, with no difference in recurrent or chronic pancreatitis, repeated endoscopic or surgical interventions, and the quality of life or costs. And this suggested a step-up approach being superior on short-term and long-term follow-up. Now, one step-up approach was deemed better than the open necrosectomy. There were other trials comparing the various surgical minimal invasive techniques such as endoscopic versus ward, which was done in the Penguin trial, in which the primary endpoint was to see the pro-inflammatory response of the interleukin 6 following surgical or endoscopic procedures, and secondary endpoints such as death or major complications. These complications again included multiple organ failures, intra-abdominal bleeding requiring intervention, fistulas, perforation and pancreatic fistulas, and long-term again as diabetes, exocrine and endocrine insufficiency, and persisting fluid collections. So the Penguin trial showed the major complications in surgical necrosectomy of up to into 80% cases, whereas in endoscopic and transgastric necrosectomy in only 20% cases. And they showed that endoscopic necrosectomy reduced the pro-inflammatory response as well as the composite clinical endpoint compared with surgical necrosectomy.
I think, can I make a point here? But I think you should also look at the severity score in the two groups before we come to this conclusion.
Yes, sir.
Severity scores, you will find that the MODS as well as the Apache 2 scores. Do you have it here? Yes. So if you see the new onset this is basically after but if you go to the baseline characteristics, there should be.
Yes, sir.
So there was, the surgical necrosectomy group had actually higher severity to begin with.
Yes, sir.
But they could randomize them equally. So, I mean, that's fine. But if you look critically, then you find that these patients to begin with had a higher severity. So before, and another thing you were saying, these interventions are leading to multiple organ failure, but it is, I must correct that it is new onset organ failure. It may not be always multi-organ failure. Most of the time, these patients only would require ventilatory support, which is just one organ failure, or
Yes.
they may just require inotropic support. So that again is one organ failure. So, I mean, the new onset organ failure does not necessarily mean multi-organ failure. It can be single organ failure.
Okay, sir.
Go ahead. Otherwise, you've done a good job. Thank you.
The other trial, which also showed that pancreatic fistulas and length of hospital stay being lower in endoscopy group, was the tension trial in 2017. And following that, there was a MISER trial in 2019, which showed that the complications in endoscopic approach were less, and even the cost for the patients was also less. Another study by Dr. Shyam Vardalaju in 2010 showed a different technique of multiple transluminal gateway, which were used at the EUS for endoscopic drainage of walled-off pancreatic necrosis. In this technique, 2 to 3 transmural tracts were created by using EUS between the necrotic cavity and the stomach, while one tract was used to flush normal saline via a placed nasocystic catheter. Multiple stents were deployed in others to facilitate drainage of the necrotic contents. Whereas in the conventional drainage technique, 2 stents with a nasocystic catheter were deployed via a single transmural tract. This too showed.
Sorry, the students, you must appreciate that how the treatment of pancreatic necrosis has evolved over a period of time, from surgery to less invasive approaches, including radiology first, and then now endoscopy. So that is what you have to appreciate, that how it has evolved. We also have with us Dr. Saraswat, who has joined us here after his term has finished from SGBGI. So I will request him also to make any comment in between. Yeah, please carry on.
Yes, Dr. Vardalaju also noted that the US guided multi-gateway technique was effective treatment option for management of symptomatic walled-off pancreatic necrosis, mitigating the need for surgery and endoscopic necrosectomy and its procedure-related morbidity. Now, after that, there have been various guidelines which have been presented by the American and the European associations, which suggest as to when to intervene. First is the patients with acute necropancreatitis with clinically suspected or a proven infected necrosis, patients with necrotizing pancreatitis and persistent organ failure or failure to thrive for several weeks, patients even with a sterile necrosis and persistent unwellness marked by abdominal distension, pain, nausea, vomiting, and inability to take orally, and patients with pancreatic necrosis associated with other complications such as luminal obstruction, biliary obstruction, recurrent acute pancreatitis, fistulas, or a persistent SIRS syndrome. So
the question here would be, do you always need to prove the presence of infection? When you go to the previous slide, please.
Yes, sir.
What is the message do you get from this slide? Do you want
so that proven
documentation of infection in the necrosis? Or
No, sir, that is not needed, sir. That is not recommended. Presence of air in the necrotic collection does suggest
no
presence of
radiological
infection.
evidence? So that is
So-
radiological evidence, yes.
Yes, sir. But
Right.
that is also not 100% that infection is present, because that
What
might be because of a internal
Right.
fistula.
What percentage of infected necrosis would manifest or present with gas in the pancreatic bed?
So I'm not sure, sir.
So they generally are 30 to 40% at most, mostly 30%. So majority will not have this radiological sign,
Okay, sir.
right?
Right,
So,
sir.
so the point here is, if the patient demonstrates features of SARS, which you are saying here, in the first week, then you do not suspect infection. Then you, or first or even the second week, then you have to demonstrate document the presence of infection. But if it is beyond 2 weeks, then clinical evidence alone, like you are saying, a patient otherwise doing well, then develops a new onset organ failure, or he has a persistent failure to thrive, right? Along with other signs of persistent pain, leukocytosis, persistently raised CRP, maybe for 3 days together, or leukocytosis for more than 3 days. So these are the patients where probably you do not need any further documentation.
Yes, sir.
Thank you.
Now, the pointer trial, which was the latest in published in 2021, helped us decide when to actually intervene, which was the timing of the intervention in necrotizing pancreatitis. In this study, 104 patients were randomly assigned to immediate catheter drainage or a postponed drainage. The immediate group was drained within 24 hours of diagnosis or suspicion of an infected necrosis, whereas the delayed group drainage procedure until the stage of walled off necrosis, which was usually more than 3 to 4 weeks, were taken. Also in this study, it showed the mean number of drainage procedures, repeated drainage procedures was less in the immediate group, and also the complications rates were less in the delayed group. So the trial did not show superiority of the immediate drainage over postponed drainage with regard to complications in patients with infected necrotizing pancreatitis. And hence recommendation was done on to treat drain these collections after 4 weeks of the inciting episode.
But again, I think another point which you should pick up from this trial is that this trial does show that if there is a clinical situation, we are talking of group of patients. If there is a clinical situation between 3 weeks to say 35 days, which is the recruitment period in this trial. So if there is a patient who is showing clinical deterioration, then you just give antibiotic for maybe 2-3 days and patient does not show improvement, then you have to do drainage.
Yes, sir.
So you can't indefinitely wait. So this trial does show that there is a place for the drainage in these patients also.
Yes, sir.
So if you are comparing a similar group where you can postpone, the results will be better if there is a postpone in terms of lesser number of interventions, lesser number of procedures.
So
Actually,
that's what the study showed, that whenever
surprised.
possible to delay
I'm
the
surprised
procedure, it will be
how-
beneficial.
Bharat, sir is saying something.
Sorry, sir.
No, I'm surprised how they conducted this trial, because you can't say that in this group we will do postponed drainage. Then they should mention that in how many patients that plan had to be changed. Is there a mention of kind of crossover from postponed to the immediate group? Because suppose the patient is deteriorating, suppose there are some complications, you will have to drain.
Yes,
You
sir.
can't say that because the patient is assigned to this group, I will wait. So did you go through I haven't read this trial.
This data of 55 and 49 patients were the final patients who underwent immediate or
Yeah, so
after
how many
crossover.
were assigned to postponed catheter drainage group, out
Yes,
of
sir.
which 49 actually had postponed drainage? I'm sure there will be patients who were initially randomized to postponed drainage group,
Sure.
but because of one reason or the other, they had to be drained in between. So that is very important, the point which Dr. Rajesh was making. So it is not that you say that we will do drainage on this day. The drainage is indicated by the condition of the patient, the clinical
status,
condition
yes, sir.
of the patient. Yes.
And another important thing, I think, which was very important in this trial, that 39% of their patients who were in postponed drainage group were actually managed with antibiotics alone without even drainage. I mean, this is one such study which has shown such high incidence of treatment of infected pancreatic necrosis with antibiotics alone. So probably.
Yeah, I think they have mentioned that. I think Dr. Saraswat here. In the AIIMS study group also, they have shown.
We can't hear Dr. Saraswat. Maybe problem with my.
No drainage.
Sir, we couldn't hear you.
Yeah, same point Dr. Saraswat was mentioning, that some patients, even with suspected infected pancreatic necrosis, could be managed without drainage, the point
Right.
which you were making.
Yes, sir.
But so all these points you need to bring when you are presenting. Of course, here you are presenting a summary, but
Yes,
these
sir.
are important points in any randomized trial. How many patients actually could not be treated according to randomization? So intent to treat, the intention to treat must have been more than 49 in the postponed drainage group. And the point which Dr. Rajesh is mentioning, that some patients who were assigned to catheter drainage, they improved so well with antibiotics and other organ support measures alone that they did not require drainage. So you can't say that because the patient is randomized to catheter drainage group, I will put a catheter drainage. If there is no need, then obviously you will. Okay?
Yes, sir.
Yes.
So to summarize, the available methods for intervention in pancreatic necrosis were either image-guided percutaneous drainage, endoscopic, which included direct or EUS guided, minimal invasive surgeries, or open surgical necrosectomies. The pancreas network of New Zealand suggested a VRP classification.
Bharat, when you are talking about the management options, so
Yes,
I
sir.
think also as was in the Panther trial and subsequently even in the further studies, is 1/3 to 1/2 of these patients can also be managed alone by percutaneous catheter drainage.
Yes, sir. The Panther trial did suggest that 30 to 35%
That
patients
also needs to be
did
kept
not.
in mind. Yeah, that's
Yes, sir.
right.
So as per the VRP classification suggested by the Pancreatic Network of New Zealand, these interventions were classified into as per the visualization that was either radiological, endoscopic, or open via the route, which could be either percutaneous, further being retroperitoneal or transperitoneal, the other being per oral, which is transmural or transpapillary, and the purpose, which was either just to drain, followed by lavage or debride. Now, the most common current treatment options included a percutaneous retroperitoneal or transperitoneal drainage, an endoscopic transmural drainage, minimally invasive retroperitoneal necrosectomy, the ward, direct endoscopic necrosectomy, laparoscopic or open necrosectomy, or again a laparoscopic or open cystogastrostomy or cystogenostomy. Coming to the radiologically guided percutaneous drainage, this is done in patients with infected or symptomatic necrotic lesions in the early phase when the patient does not seem to be improving with the antibiotics and a delay of 4 weeks cannot be achieved. And in those walled-off necrosis who are too ill to undergo endoscopic or surgical interventions, this can be again transperitoneal or retroperitoneal. It prevents further bacteremia and also serves as a bridge to necrosectomy such as ward. And it has been shown that more proactive upsizing and repeated drainage procedures can even prevent necrosectomies.
And in some patients, actually, it may have to be transgastric, transvisceral, isn't it?
Yes, sir. Transvisceral also.
Yes.
The endoscopic guided drainage, it is recommended that EUS should be preferred over the conventional transmural drainage for initial endoscopic drainage. And in this, a progressive balloon dilatation of the cystoenterostomy fistula starting at 6 to 8 mm is done, and potentially increasing it during the following days, followed by an endoscopic transmural drainage with a stent placement. In this, either plastic stents or a LAMS, that is a lumen opposing metallic stent, can be used. And it has been shown that in certain studies that self-expanding metallic stents, that is LAMS, appear to be superior to the plastic stents. For example, in this particular study, among 94 patients, Vaughan resolution rates, although did not differ between the plastic and the metallic LAMS stents, however, the SEMS appear to decrease both the need for repeated necrosectomy procedures and the risk of intervention-related damage. Now, the European guidelines recommends performing endoscopic or percutaneous drainage of suspected or confirmed infected Waldorf necrosis as the first line interventional method, taking into account definitely the location of the Waldorf
Bharat?
necrosis.
Sorry, Bharat, are you done with your endoscopic approach?
So there are a few steps, there are a few more slides, sir, 2 to 3 slides. And also, the ESG also suggests that a percutaneous drainage should be strongly considered as an adjunct to endoscopic drainage if the necrosis is seen extending deep into the paracolic gutters and pelvis, or for salvage therapy after endoscopic or surgical debridement. And again, ESG suggests delaying the first intervention for at least 4 weeks if it can be tolerated by the patient clinic. Endoscopic direct necrosectomy is also an option. It's usually done when there is limited necrosis who do not adequately respond to endoscopic transmural drainage. The European guidelines recommends exclusive use of carbon dioxide instead of air to decrease the risk of gas embolism, and also recommends restraint, again, use of high flow water jet system, hydrogen peroxide, or any vac closer dressings to facilitate debridements because of insufficient evidence. In the absence of improvement following endoscopic drainage of Waldorf necrosis, a direct endoscopic necrosectomy or a minimal invasive surgery is to be preferred as a next therapeutic step. And in this, minimal invasive is definitely preferred over the open surgery. So that was the endoscopic part, sir.
Bharat, can I make a point here? So I think, you have no host of choices available to you in terms of intervention. So it is important for you to understand in which patient, we are talking group of patients, but what particular choice in which patient, that also needs to be defined, because suppose you have a collection in the retrogastric area, right? So this patient is amenable to transgastric laparoscopic necrosectomy, endoscopic necrosectomy, or endoscopic drainage. So what procedure should be suitable to a given patient also should be known. And that would be decided, one, by the geographic location of the collection, but also important is the physiological condition of the patient, right? And that may sometimes change you may not be able to use the best approach and may have to do compromise to use it as a bridge. And most important is the contents of the wound, whether most of them are liquid or solid. That is very important, because what we have seen is that if the contents are more than 70% solid, then even if it is retrogastric, which is easily approachable by endoscopic, these patients, even after multiple sittings of endoscopic necrosectomy, do not do well and they would require surgery. So in these patients, maybe upfront surgery after, tiding over the sepsis situation, probably surgery would be a best choice. So keep that in mind when you describe this.
Okay, sir. Coming to the indications for surgery, which can be either minimally invasive or open. First is definitely the infected necrosis with continuing clinical deterioration. Also as a continuum in a step-up approach, which after percutaneous or endoscopic procedure. If the patient has an acute ongoing bleed, when endovascular approach or an embolization is unsuccessful, patient presenting with bowel ischemia, a bowel fistula extending into the peripancreatic collection, leading to persistent sepsis, and also the acute pancreatitis with abdominal compartment syndrome. Now, the timing of surgery again was recommended to be delayed as much as 30 days if possible, depending on the clinical condition of the patient. And the benefit is that there is demarcation of the necrosis from the vital tissues, therefore making the dissection easier. Enough time for optimization of the patient with nutritional improvement. It has been shown that there is less chances of bleeding, and an effective necrosectomy can be done after 4 weeks. The various operative techniques available are open, laparoscopic, or percutaneous. And again, depending on the route, it can be retroperitoneal or transperitoneal. And transperitoneal mostly is through the mesocolon or the gastrocolic ligament entering the lesser sac.
Transgastric also.
Yes, sir. If the patient has a symptomatic Waldorf necrosis with sepsis or organ failure, then an open necrosectomy with an open packing, or a necrosectomy with closed packing, a programmed open necrosectomy, or a continuous closed post-operative lavage can be done, or a minimal invasive surgery. Whereas in a symptomatic walled off necrosis without sepsis, a cystogastrostomy or a cystogenostomy can be done depending on the location of the collection and how much of a bulge against the stomach or the wall has matured. And endoscopic intervention, if not possible, these procedures are done with extensive debris, increased risk of bleeding, and a difficult access endoscopically.
Dr. Rajesh, maybe for the student benefits, many a time I have seen students fumbling on this, that suppose you take up a patient and you find fluid, but there is a lot of necrotic material also in the cavity. So in such situations, whether an internal drainage can be done and in which situation?
So I think, sir, I mean, if we are considering these as retrogastric collections, we should always do internal drainage, because incidence of pancreatic fistula is 2/3 will have external pancreatic fistula. This is a separate matter that only a small minority of these patients would require intervention surgically, and they would, external pancreatic fistula would resolve on its own with conservative management. But that remains a major issue in all these patients where we are planning surgical intervention. So internal drainage, wherever it is possible and wherever stomach is available as a route towards that, transgastric and cystogastrostomy should be done to both necrosectomy as well as for internal drainage.
So if the wall is mature and the cavity is suitable for internal drainage, the presence of solid necrotic debris, relatively small amount, is not a contraindication for internal.
Not at all, sir. Not at all. I don't think the necrosum per se is a contraindication. It is only the wall should be thick enough and in opposition. Yes, sir.
Yes, sir. For necrosectomies, open necrosectomies, either a midline or a rooftop incision is used. And the approach, again, the importance is that usually the necrosis and the sepsis in these patients is limited to the supracolic compartment. So therefore, the advantage, one advantage of entering through the gastrocolic ligament is that the sepsis gets contained to the supracolic compartment only. Whereas if we enter through the transverse mesocolon, there are chances of injury to the middle colic vessels. And also there are chances that the abscess then will drain further into the infracolic compartments.
So
These are diagrams.
Transverse mesocolic approach per se, you would take care that you are not close to the middle colic vessel. You just look at the bowel, a small bowel loop, which is adherent to the mesocolon.
Yes,
You
sir.
separate that loop, keeping in mind the arcade around the transverse colon as well as the middle colic vessels. And when you separate that bowel loop, there will be a pus which will come out from there, and that you can gradually enlarge towards the direction of the opposite to the direction of the blood vessels.
Yes, sir.
And gain access to this cavity.
See, again, I will say that whenever you are describing an operative procedure in the exam, you should describe it preferably in the first person, and also just don't describe the steps. Also say what precautions you will take, what things you will look for. So, for example, when you are approaching the lesser sac, either through the gastrocolic omentum or through the transverse mesocolon, this is not like opening the lesser sac in a pancreaticoduodenectomy or in chronic pancreatitis.
Exactly.
This is all inflamed, thickened, everything is adherent to each other. So you should say very carefully, I will identify the border of the stomach, I will see where the colon is, I will identify a safe window, taking precaution not to injure any vessels, this shows the examiner that you have done, you have assisted, you have seen these cases. So it should be different from a textbook description of just saying what are the steps of operation. Okay.
Okay, sir.
And in your clinical practice also, it is very important, because one of the common problems is causing an injury to a viscus or to a vessel. So you have to be very, very careful when opening the lesser sac or approaching the lesser sac in these patients.
Yes, sir.
Yeah.
So this diagram here shows the after approaching through the gastrocolic ligament, the necrosum present in the lesser sac behind the stomach, and a pancreatic debridement done by continuous irrigation and a blunt dissection is preferred. The operative points which are important during necrosectomy are a blunt dissection with finger, sponge holder, or suction cannula should be done. If the tissue planes are not opening up, aggressive dissection should not be done. only mature organized necrotic tissue should be debrided, and it is not necessary to remove every piece of necrosis. An organ preserving approach should be done. Unnecessary mobilization of colon should not be done. Avoid avulsing bridges of tissue bands which are seen in the cavity. If there is massive bleed recommended as more than 3 units of blood or cardiovascular instability intraop, then it is better to pack and discontinue the procedure. And careful, again, dissect carefully so as to avoid injury to any splenic vessels, to avoid any splenectomy. And careful placement of drains for drainage and irrigation should be done. So
sorry, my colleague Dr. Ajay Sharma is here. Ajay, any tips you would like to give for doing either minimal invasive or open surgical necrosectomy?
Morning, everybody. I think it is a very good description which already has been presented. Except for few points which I was just thinking while the discussion was going on. Whenever you are using a transverse mesocolic approach, usually this approach will be used when you have a large bulk of the necrosum or a cavity presenting through the transverse mesocolon. It will never happen that you are having a collection in the lesser sac not presenting into the transverse mesocolon, you still want to use this approach. It will never happen. So when you have a impending abscess in that area which is presenting, it is very unlikely that you will injure the vessel, because as Dr. Rajesh has already told, that it will be either it will be ruptured or bound to rupture at that site, and then you can gradually increase the size of that site. Second thing, when you were telling about the transgastric approach for any collection with a necrosis, the necrosum is not a contraindication. I think the absolute contraindication to use that approach is a gross infection being present over there. Because there will be, with that infection, there will be a lot of inflammation and the healing may not be adequate in the post-operative period. So that may be the one condition in which I would say that I will never use a transgastric approach to drain that collection. It is not the amount of necrotic material over there. Even if you see a fluid in the CT scan, you will still have a lot of necrosum over there. Okay, sir. Now, regarding the minimal invasive approach, I think for a minimal invasive approach to have it through the transverse mesocolon is nearly always impossible. If it is presenting over there, even if you lift up the colon and if you just put a puncture, it will cause a spillage into the infracolic compartment, and then you have to do a continuous irrigation into the pelvis and then drain. So whenever we have attempted that, they failed, and then subsequently you have to open it because you have to do a good lavage. This is usually not that easily visible with the mildly adherent or the dilated and the edematous bowel loops. Laparoscopic or a minimal invasive approach is almost always suitable for a solitary collection, one thing, a large collection in which you know that it is going to be drained between the colon and the stomach, where you can get a good approach. So good CT scan showing that area where you can enter that site is very required. Now, same thing implied for both laparoscopic as well as a open surgical approach, which Dr. Kapoor was saying, that whenever you are going into that lesser sac area, you have to be always very careful that you identify the stomach and colon. If you injure either of the two, because in that inflamed area, everything looks alike. So in that inflamed area, and with on palpation, you can still feel, but with the laparoscopy, it will be difficult for you to identify that area and the vessels. So both, then it becomes more difficult. So until you have already made your map laparoscopical on CT scan for a laparoscopic approach, I don't think you should go ahead by a minimal invasive technique. And a better minimal invasive technique is always, if you can go through a retroperitoneal approach, that is very helpful. I think we'll be coming to that.
Yes, sir.
Another important point is, as Dr. Ajay said, that your roadmap for surgical approach by CT, but it has to be immediate pre-op CT. You cannot rely on CT which was done 5 days or 7 days ago. Pancreatic necrosis is one condition where frequent CT scans may have to be done, and definitely you should have a immediate pre-op CT in the last 1 or 2 days, so that you don't miss anything, or the location or size of collection or necrotic cavity has not changed as compared to previous CT scan.
So I just want to add one more point, that sometimes when you open and you do not find a bulge, and then you have to look for a point to enter. At that situation, if you have a pigtail in place, if you can actually, if it is not approachable through surgery, in open surgery or laparoscopy, say it is positioned at an odd point, but you can still use that pigtail. What I mean by odd point is it is through the intercostal space. So obviously it is difficult to use that, but you can use that pigtail. You can instill maybe 300 or 400 ml of saline, whatever is easily visible, which can easily go, and that cavity can bulge, and then you can access that cavity with the use of this external irrigation fluid.
Yes, sir. Carry on, Bharat.
So after open necrosectomy, there are various options as to how to treat the patient. That is, one is with a closed drainage, the other with a closed lavage, and also a planned re-exploration, in which usually a laparostomy is done with temporary abdominal closure, either with zippers, and re-exploration once in every 2 to 3 days is done till all necrotic material is cleared. So this picture here shows multiple drains put into the lesser cavity after necrosectomy. And this is a diagram showing closed packing system.
Just a second, Bharat, can you go to your previous slide again? Yeah, previous to this. Yeah, just want to emphasize that this is a very good demonstration of putting the drains. But if you see that if you are irrigating from the drain, which is close to the other drain, which has to let it out, it is not going to lavage your cavity. Getting the point what I want to emphasize?
Yes, sir.
Always the drain which is going to push in the saline and the drain which has to suck has to be slightly away, so that even if you put 10 ml, it will come out through the drain, then it is of no use until unless it lavages your cavity, until unless it removes the necrosome which is left over. So this is a very good representation of that what you have to place, but then you have to be very cautious from which you are pushing in the saline and from which you want to get it drained.
Yeah, I think this one is, he has categorized into 3 groups. No? That post-surgery, you are doing closed drain. I think it's a closed drain. The one, if you want lavaging, then obviously you put it from one side and other side, and those openings are, he has done that way. See, he has combined it. But then, see, these 2 drains on the right of the patients, I think they will be, and this will be used like
But Dr. Rajesh, how frequently in your practice or in others' practice now this planned re-necrosectomy or planned re-laparotomy, is it becoming less and less now?
Yes, sir, it is becoming less and less. And I think more and more we are actually, I was waiting, maybe he will cover that. We don't do this open laparotomy. We do no minimal access because most of the patients are following step-up approach. So along the pigtail catheter only we give small incision and use our.
Yes, sir. I will be covering that, sir.
So that part probably. So this we are not seeing very often most.
Yes, sir.
Yes, carry on.
Now the advent of minimal access interventions were they are present due to reduce access trauma, to reduce the surgical stress and the pro-inflammatory response, and also to delay open surgeries as much as possible. There are various methods. Firstly, we had discussed the percutaneous, other was laparoscopic. In this, the collections must be organized. The advantage is that complete removal possible in a single stage, and also simultaneous cholecystectomy if needed in case of a necrotizing cholecystitis was also possible. And access to extra pancreatic collections in the perinephric space was possible. But the limitations were that there were peritoneal contaminations and adverse effects of pneumoperitoneum in critically ill patients were seen. The next technique route was the retroperitoneal approach, which was mainly used for collection of the body and tail of the pancreas. It limits the peritoneal contamination and has now become a favorable option over open surgery. The limitation is that it has limited access to the extra pancreatic collections and often needs multiple procedures, and even after the ward, there are chances of placement of PCDs possible. So the percutaneous option, there are 2 ways in which we can do this procedure. One is the percutaneous minimally invasive retroperitoneal necrosectomy, in which a pre-placed percutaneous catheter over which a tract balloon is used to dilate the tract, and a nephroscope is inserted with the sheath, and the necrosome is removed with the graspers, and finally a lavage drain is put. This procedure showed a morbidity of 10 to 20% and mortality in up to 20% cases. The other approach is the video-assisted retroperitoneal dissection or debridement, in which a retroperitoneal approach over the previous PCD site or a pre-marked site by USG or CT scan is used. A trocar inserted, a trocar and a laparoscope with additional instruments such as a grasper is used, and adequate necrosectomy is done with drain placements. So in ward, we put a 5 centimeter subcostal incision in the left flank near the exit point of the percutaneous drain, and the solid debris that is encountered first can be removed bluntly by using long grasping forceps. This is done blindly, and subsequently a laparoscope is introduced into the necrotic cavity, and hence more central necrotic debris near the body of the pancreas can be removed. And this technique is more suited to patients with central distribution of necrosis that is extending down towards the left paracolic gutter. But it is quite ineffective in reaching necrosis to the right of the mesenteric vessels. This diagram here is showing the steps as mentioned previously with the ward technique. The other option is a surgical transgastric debridement, which can be done either laparoscopically or open technique. And in this, an anterior gastrostomy to access the posterior wall of the stomach is used for transmural access to the necrosis cavity. This is done depending on the bulge which is felt intraoperatively. And nasogastric tube is placed across the posterior gastrostomy into the necrosis cavity for post-operative lavage. And this, the relatively large size of the cystogastrostomy has the potential benefit of durable enteric drainage of a pancreatic fistula in case of a disconnected pancreatic duct syndrome also, which I'll be covering shortly. And transgastric approaches are best suited to the patients with centrally located necrosis.
Anterior gastrotomy, not gastrostomy. You have written gastrotomy, but you said gastrostomy.
Sorry, sir, gastrotomy.
There is a difference, yes.
Now, very importantly, these patients require intensive post-operative care in the ICU with proper thrombophalanxis, vigilant routine monitoring for signs of sepsis, any new onset organ failure, any bleeding. And depending on these, a CT might be required. And if an undrained collection is noted, so the patient might undergo a repeated ward or a repeated drainage in every 2 to 3 days, repeated assessment of the wound, and nutritional support, be it partial parenteral and enteral, but preferably an enteral option is preferred. And adequate irrigation till the fluid becomes clear is done post-operatively. So the
sorry, Dr. Rajesh, any tips you would like to give to the students about the volume of lavage fluid, which fluid, how long, how much per day, any recommendations, any of your practices?
Sir, if we have done, if we have done surgery which is beyond 4 or 5 weeks, then most of the debridement can be achieved during the procedure. However, the situation is when surgery is done little earlier, maybe close to the 4th week time, then debridement may not be as complete because we only remove tissues which are easily coming. So we leave those tissues where we encounter bleeding, or there are fibrous tissues which could be blood vessels. So in those cases, when we drains, then we can go up to even 4 liters, 5 liters. There is no limit. Only limit is the patient feeling pain and if the temperature is not being maintained. These are the two, because the cavity is small and we instill too much of fluid, patient will start complaining pain. And that also can lead to rupture of those contained cavities and can lead to ascites, and patients can present with peritonitis also. So those are the two precautions which one has to take. If patient is alone, volume may not be any limit. As much volume must ensure how much is going in, how much is coming out. And when it is clear, then start reducing the volume gradually. Keep measuring the amylase levels in between. So closer as the cavity starts shrinking, the volume keeps on decreasing. Then you leave it to dependent drainage. And then once the amylase is also normal, one can think of removing these plants.
Is there any risk of fluid overload or hypernatremia if we use large amounts?
No, sir. We not, because these are not, I didn't find these as absorptive surfaces. These are all dead tissue which is lined and there is granulation tissue. So there is no absorptive surface which leads to dilutional hyponatremia or anything like that.
Yes,
Not an
Bharat.
but yes, temperature, if it is cold weather, they do feel chills because the volume is large, and they do feel pain if suddenly the fluid is rushed in. So it has to be a gradual in a drip where the inflow and outflow is continuously monitored. It is a very labor intensive procedure and need a dedicated team to do this.
What about use of nasogastric, nasojejunal tube for feeding or feeding jejunostomy as a adjunct to when you are doing necrosectomy, surgical necrosectomy?
We always have these tubes for feeding, whether it is nasogastric, nasojejunal, or if nothing available, then sometimes, and if it is possible, then feeding jejunostomy if it is open necrosectomy. We always establish enteral feeding.
So if already there is a nasojejunal tube,
Then we don't change, then we continue with that.
also one has to be careful that sometimes the jejunum is so edematous, thick, inflamed that sutures may be cutting through, and then trying to place a jejunostomy tube may in fact be a problem. So it is always better to rely on a per nasal tube rather than doing a surgical jejunostomy. Yes, Bharat, carry on.
So finally, the question arises, what do we actually do? And this is largely based on the location of the collection, the extent of the disease, the clinical status of the patient, that is the performance score, availability of what equipment in a particular department, and the local expertise available. Eventually, the goals of therapy are all similar. That is, quickly decrease the SIRS response, mitigate any organ failure and prevent it, and inducing as little added stress as possible. So the best practice advice is the step-up approach, which is summed as 3 Ds, which is delay as much as possible up to 3 to 4 weeks, possibly drain, and then even if the patient is not improving, then go for debridement, and which uses all these procedures in the armamentarium, that is percutaneous drainage, endoscopic, minimal invasive surgeries, or finally an open necrosectomy.
Bharat, just in that delay, now you mentioned delay. It is preferably to wait till 4th week, but delay is actually emphasizing the fact that it is not mandatory to go in 4th week. Delay it even more. More you delay, safer is the patient.
Yes, sir.
So it does not mean that at 4th week. What fourth week is just you have to go up to 4th week, but even if you can delay it up to 6th week, 8th week, it is more beneficial to the patient.
Yes, sir. So this flowchart here helps us summarize the treatment in a case of a suspected or a diagnosed infected pancreatic necrosis, necrotizing pancreatitis. That is, if it is less than 3 to 4 weeks from the disease onset, we try to temporize it with antibiotics. If resolution well and good, if the patient does have an abdominal compartment syndrome or a complication such as a hemorrhage or a bowel perforation, a patient is taken immediately for Radiologically. If still the patient has an ongoing sepsis, the first, as per the step-up approach, we do a percutaneous drainage or an endoscopic drainage. And if there is ongoing sepsis beyond this point also, then a ward or an endoscopic debridement or a minimal invasive surgery or laparotomy with open necrosectomy can be done. So there are certain complications which we must keep in mind after necrosectomies, which can be grouped as either early or late. Early can be any organ failure, multiple, and any hemorrhage or perforation. Late complications such as pancreatic fistula, biliary stricture, any enteric fistula, delayed collections, and eventually on long-term patients having incisional hernias, exocrine or endocrine insufficiencies. Patients may have intraoperative hemorrhage. These are usually due to either an early procedure or before the necrosome has matured, or due to over-enthusiastic necrosectomies going into wrong planes. The most common cause is a venous bleed here, usually settles with correction of any coagulopathy and with local pressure. Secondary hemorrhage, usually after patient is in the ICU. The most common cause is an arterial bleed because of uncontrolled sepsis around a major vessel. In this, the mortality exceeds 30 to 40%. In such cases, an emergency CT angiogram should be done, and an angiography with embolization should be done. The other complication is an enteric fistula, which can occur, and there is spontaneous discharge of collection into the GI tract. It is noted that when it is present with the stomach or a duodenum, this can decompress the collection and often result in clinical improvement without any interventions. But it has also been noted that fistula into the colon often results in persisting sepsis and poorly controlled collections. In such cases, defunctioning colostomy or ileostomy might be required. Now, most of these patients, up to 1/3, eventually lead to a pancreatic fistula, which occurs due to disruption of the main pancreatic duct with the leakage of amylase-rich fluid. And prolonged catheter drainage will also lead to maturation of the fistula tract. And once there is resolution of sepsis and any significant collection, PD stenting may result in resolution of a persistent fistula. And the ESG guidelines suggest removing the percutaneous drains when the effluent is clear. Production is less than 50 ml in 24 hours with no evidence of a pancreatic or percutaneous fistula. The other complications to be kept in mind is a disconnected pancreatic tail syndrome, in which there is complete separation of the MPD. The treatment is usually either transpapillary stenting, a transmural EVH guided drainage of the collection, and often a salvage distal pancreatectomy. If the disconnected left pancreatic remnant is detected in the early phase, which is within 2 to 4 weeks, there is evidence to give supportive care of systemic inflammatory response, enteral nutrition, and if there is concern for infection, then a PCD with antibiotics can be started. If it is in the late phase, that is more than 2 to 4 weeks, again with supportive treatment.
Bharat, can you predict, looking at the CT scan, that this patient is likely to develop disconnected duct?
Sorry, so I didn't get the question.
Third week. The question is, looking at the CT scan in 2nd or 3rd week, because you are talking of 2 to 4 week period,
Yes,
can you look at the CT scan and tell us that this patient is most likely going to develop disconnected pancreatic duct?
So more than 50% necrosis of the body and tail does have correlation with the disconnected pancreatic duct, sir. Otherwise, I'm not sure, sir.
I mean, the necrosome has to involve the area where the duct traverses.
Yes,
So
sir.
if you find that in the body, there is full thickness, whole parenchyma is necrosed. So this patient is more likely to have necrosome, disconnected duct. More important is that, it is not body and tail. More important is that the tail should be viable. If the tail is also gone, then it is of no consequence. It is inconsequential.
Yes, sir.
Viable tail has to be there for this juice to become clinically entity.
Yes, sir.
Dr. Rajesh, would it be correct to say that it also depends whether there are necrosis is involving the pancreatic parenchyma or whether it is peripancreatic necrosis?
Parenchyma.
Parenchyma, of course, sir, parenchyma.
So to summarize the seminar, firstly, infected pancreatic necrosis will mostly require invasive interventions, be it percutaneous, endoscopic, or minimal invasive or open surgeries. The current evidence prefers PCD or endoscopic interventions followed by minimal invasive or open necrosectomy. And interventions within the first few weeks are associated with worse outcomes and should be reserved for infected necrosis and severe clinical deterioration. A step-up approach has better results, which is usually done by 4 to 6 weeks. Patients with treatment failure after percutaneous or endoscopic drainage should be considered for necrosectomy. And a combined approach, a multidisciplinary team approach, are superior to single interventions. And important is the incorporation of timing of the disease process, anatomical orientations, individual clinical scenarios, and the local expertise and skill sets available. These are all paramount to select the optimal intervention and the technical success in such cases. Thank you, sir.
So Bharat, in 1 or 2 lines, can you tell me how you do the necrosectomy per se? Once you have entered the lesser sac, how do you remove the necrotic material?
So it is done by irrigation and sponge holding forceps, usually all by blunt dissection.
Anything else? Irrigation, sponge holding forceps, what else?
But before you hold a sponge holder, do you do anything? I think more important before that would be digital mobilization.
Your finger.
Yes,
is
blunt dissection, sir, with finger.
That will be more important. Then you take this sponge holder and remove this.
Yes, sir.
If you don't mobilize this and start using this sponge straight, then you can damage vessels.
Okay, sir.
Sorry, sir, please go ahead.
You should also say that you don't use any sharp dissection. So there is no place for knife, scissors, cautery. It is
Yes, sir.
all blunt dissection with
Blunt dissection.
suction, irrigation, sponge holder, finger, gauze, sponge. So you remove what comes easily. You don't pull anything, you don't cut anything.
Yes, sir.
Yeah. Students? Yes.
When we can,
Loud, speak loudly.
sir, in ward, how can we be sure that we are not injuring any vessel when doing necrosectomy? How to avoid?
We don't know.
But, sir, not.
Bharat, could you hear?
No, sir, I couldn't.
Either or. Come here.
How to avoid injured vessels during a ward approach?
So he wants to know, when you are doing ward, how do you avoid injury to the vessels?
So again, overzealous dissection should be avoided. Only necrosis which is coming off easily should be taken off. Any point where there is slight bleeding which is starting, further dissection should not be done. It is not necessary to remove the complete necrosis and get a good viable plane. That is not suggested.
So Krishna, while you're doing necrosectomy, if you see bleeding, that means you are going into viable tissue, number one. Number two, if the vessel is viable, he mentioned in one of his slides that there will be a fibrous strand. Once you see fibrous strand in a necrotic cavity and it is not coming easily with your finger, that means that there is a vessel running in it and you don't try to remove it. Dr. Rajesh, any other?
No, I think this is answer. I mean, you should remove only whatever is easily coming out.
Yes,
Leave
that's the
for
most.
the drainage.
That's the most important thing, that you remove only what is easily coming with gentle blunt dissection with the maneuvers that we have already mentioned. Yes, online students, any questions? Faculty, online faculty, any comments? Govind, yes, come in. Ask your question.
Nowadays, there are papers coming up against upfront approach also, against step-up approach also, supporting an upfront surgery as a one-stop shop for every drainage of collection. So what is the take on that?
What do you say?
Hello?
You mean surgery in the first go for every
Surgery
patient?
as an upfront in the first step. No, I am asking for specific indications, sir. I have seen a couple of papers coming up against step-up approach. But is there any specific indication, or can we group such kind of patients which require an upfront surgery against step-up?
That would be step down then. If you're doing a front surgery, then rest is all step down. So Rajesh, any, I mean, except for perforation, bleed and all, which you already mentioned, but for pure necrosis, I'm not sure whether that approach would be any situation.
I think if we have a situation where we are dealing with most of the necrosome is solid, it is going into both the paracolics, also into the along the mesocolic vessels, into the retroperitoneum, along with this lesser sac. If that is a situation, then probably we will need multiple minimal access approaches to deal with this. And if the patient's condition is such that it can withstand the insult, then maybe single open approach may be a good alternative. But you should have a patient who can tolerate this procedure, because most of these patients will actually develop organ failure after this.
Abhijit, you would like to make any comment? I see you are there. Please unmute yourself, come in.
I think most of the
Yes.
things have already been covered. There's nothing much to add. We've, as rightly mentioned, sir, we've also shifted to the step-up approach, and our main step for surgery is minimally access. We use the percutaneous route, dilate it, and then usually do what where conventional interventional radiological procedures fail. So I think I'm not sure about upfront surgery for,
Hmm.
pancreatic necrosis per se, apart from the routine indications of perforation, bleed, which was mentioned. I'm not sure about. I still feel that step-up approach is safer for our patients, and I've seen the results improving. Initially, so during my training periods, you remember we used to rely on open surgery, and the results were not as good. So this clearly made a difference.
Yes.
From
Yes.
minimum to maximum.
Ajay wants to add something. Yeah.
I think there are very clear three indications for not doing a step-up approach. One is a major complication, perforation of the bleed. Second, the patient requires multiple drainage tubes, which may be more than 4, more than 5. Any center can have its own criteria. So doing a single time drainage of all this collection may be preferred. And third thing is non-availability of an interventional radiologist. So these are only 3 indications in which you will require a direct surgical approach.
Dr. Saraswat, anything you would like to, what surgical students should know about endoscopic management of acute pancreatitis? Or
Thank you, Dr. Kapoor. I think it's again an area in evolution. The evolution has happened. I think Dr. Bharat talked about plastic stents. Once there is more than 15% solid content on endoscopic ultrasound in any WON or walled-off necrosis, only metallic stents, lamps need to be used. Obviously, retrogastric, something that is easily accessible from the stomach, are the collections that are drained, although they may not be bulging collections, but under EUS guidance, because splenic vein thrombosis, collaterals may not be uncommon, and there is an increased bleeding risk in those situations. Usually, these stents, the lamps, are anchored with a double pigtail stent so that any possibility of migration may be minimized. And then 24 hours later, going in, taking a look inside the cavity, doing lavage and debridement, removal of necrotic tissues can be attempted. So that would continue. And generally, after 4 weeks or so of placing the lamps, they are removed to minimize the chances of bleeding from the walls of the stomach that has been reported in some situations. Migration of these stents is a problem that may happen technically if we do not anchor them properly. But otherwise, with this approach, and a very large number of collections can be dealt with. And I think, as Dr. Bharat pointed out clearly, collections that are remote from access from the stomach will need to be dealt with directly with a percutaneous or other approach. So I think with this serial lavage approaches, a lot of patients with walled-off necrosis can be handled effectively. And particularly, this has a place in very sick patients, patients who may be in the ICU on the ventilator, and it's difficult to do surgery in them. Bedside endoscopic drainage and placement of lamps has been done in situations. So I think the room for endoscopic management also, for the disconnected pancreatic duct syndrome, there is a clear situations where one would do attempt endoscopic bridging of a possible disruption if it can be crossed. That happens only in 10 to 15%. In the majority, collections can be drained internally, and the intervention radiology help may have to be sought. The place for endoscopic interventions in pancreatitis and its complications is steadily going up. And I guess expertise, endoscopic, percutaneous intervention, radiologic, and surgical need to keep pace to give the best results to the patient.
Shaswat, anything you want to add? Okay. Dr. Rajesh, any final comments?
Thank you so much, sir. It was very enlightening for me also.
So I just want to have a feedback from the students that do you like this format as opposed, in addition to case presentations? Because I thought that case presentations are being done in the Monday morning, the Dr. Rebala Pradeep session. And by the time we reach the end of the session, we cannot cover the operative part. So that is why I thought that in this, we will concentrate more. So I would like to have a feedback from students. They can send me a message, a personal message on the WhatsApp group, JST group, whether you would like to continue with this format. Also, what I had in mind that in the operative surgery session, the student should be, this is more like a seminar. It was very good. It is also very educative, but I would like the students to present indication, contraindication, preparation, procedure, and complications. And then the faculty will moderate, because that is how in the exam you will be asked. So yes, you should add some information, literature, and knowledge also, which is very useful to put the thing in the correct perspective. So Dr. Anand, my colleague, will make the further schedule, and please follow that schedule. If for some reason the student who is allotted the session cannot make it, then now you know who are the other third-year students. Please make a mutual exchange. Let us not session go by default. So I will try to get experts related to the subject topic. Also, my request to young faculty colleagues who join online, please chip in, please make your comments, ask questions from the students, because my job was to initiate this process, but all of you have to kind of carry on this academic activity. Thank you, Dr. Rajesh, once again. Thank you very much. Dr. Avinash, my former fellow who is now in Ahmedabad, is offering technical help. So all these sessions are recorded. He then puts the video on YouTube. There is a YouTube channel which we are going to create. So as soon as that is done, we will send the link to you. Thank you.
Thank you.
Thank you very much.
Thank you.
Thank you, everyone. Thank you, Abhijit.
Thank you.
Thank you. We will close the session now. Thank you, Bharat. Thank you for your presentation.
Thank you, sir.